The next presentation, Dr. Dobrichkov.
Good afternoon. Well, hi everyone again. Before I start, I would like to ask you how many of you have ever used either thrombectomy or aspiration device? Okay. And how many of you routinely use rheolytic thrombectomy for arterial occlusions? Okay, so many. I have no disclosures. So there are two main rheolytic devices on the market, Jetty and AngioJet. I will speak particularly about AngioJet because this is my personal experience. I use it in my daily practice. So how it works, high jet saline streams are moving from the tip of the catheter backwards through the lumen of the catheter, which has a shape like hourglass. So, and there are two small holes in the narrow part of the tip of the catheter. So first, the jets are spraying into the thrombus, causing the fragmentation of the thrombus, and after that, the high-velocity jets, which are moving backwards, are causing Bernoulli effect. So a negative pressure occurs, and the thrombus fragments are sucked into the catheter back to the machine. And those extreme forces destroy the red blood cells, which causes release of free hemoglobin and adenosine. That also can traumatize the vessel wall and generates microemboli and sometimes macroemboli. So this is my concept for the three different types of complications during rheolytic device use. So first we have this systemic cascade of complications caused by hemolysis. We have local cascade caused by mechanical trauma and the distal cascade caused by microembolism. So all those three cascades interact with each other, and one leads to another. For example, a complication from one of the cascades can provoke a complication in the second one, which can provoke a complication in the third one. So our mission is to minimize all possible complications. So first, let's start with the systemic cascade. So it's hemolysis mediated, and the high velocity jet streams destruct the red blood cells, which leads to releasing of free hemoglobin and adenosine. So the hemoglobin is toxic for the kidney, so it could lead to acute kidney injury, and the free adenosine release leads to bradyarrhythmia. So let's start with the bradyarrhythmia. Thankfully, it occurs quite rarely during arterial thrombectomy. So the hemolyzed red blood cells release adenosine, which leads to AV block. So if we observe a case of bradycardia, we should stop thrombectomy immediately, wait for at least 1 minute or more, and usually the problem resolves itself. If not, the patient should be medicated. Another problem is with the hemolysis and acute kidney injury. As I mentioned before, free hemoglobin is released, which forms obstructive tubular casts, and that causes direct oxidative damage to the tubules. The main risk factors are patient-associated, like chronic kidney disease, malignancy, recent surgery, and male gender. And on another side, we have procedural factors, which are usually iatrogenic. Some of them are iatrogenic. Arterial use, which causes more often acute kidney injury, that's also associated because patients are usually elder and with many comorbidities, and usually have underlying chronic kidney disease. Also, drop of hematocrit, that's usually a sign of hemolysis. When we overexceed the runtime, that's another procedural factor, and a long thrombotic lesion. So to prevent acute kidney injury, first we should start with a good hydration combined with sodium bicarbonate before, during, and after the procedure. We should check the baseline labs of creatinine, blood count, and electrolytes, and hematocrit to check for to check the kidney function and possible hemolysis. And also we can administer aminophylline before the procedure to prevent bradyarrhythmias. So these are how and when to use aminophylline. You can take a picture of it. I'm not going to use more time about it. So we should always keep the runtime discipline. So we should do the procedure intermittently with separate pulses, about 20 to maximum 25-30 seconds each. After that, we should stop the procedure for 20 to 30 seconds, wait, and continue after that. We should never overexceed the maximum thrombectomy time, which is 30 seconds, equal to 30 milliliters, usually using the Solent, Omni, and Proxy catheters. Also, we should always check for any kind of any visual signs of hemolysis, like first checking the tube of the catheter for dark brownish aspirate, and also we should check the urine of the patient for dark brownish discolorization, which is sometimes mixed with hematuria, but actually it's a hemoglobin urea, and it means always tubular damage. So this is easy to memorize. My concept for the definitely stop criteria, when we should stop the procedure, wait for a while or a bit longer, and after that proceed, or in sometimes we should terminate the procedure and think for another option for revascularization, or if it's feasible to continue the procedure in another day if a patient is not in limb-threatening ischemia. So S stands for severe bradycardia, T is for total runtime, O is for obvious hemoglobin urea, and P is for poor clearance despite the long runtime. What does it mean? So if we, for a thrombectomy time for over 180 seconds, we have removed less than 50% of the thrombus. That means that maybe we will fail to clear the whole thrombotic lesion in less than 300 or 300 something seconds. So if acute kidney injury develops, we should continue with forcing the diuresis, avoid additional nephrotoxins, for example, contrast and other angiograms, and if it's needed, dialysis should be performed. Actually, the dialysis might be needed in 1 to 13%, according to literature, not 13. The good time is that in almost 80% of the cases, the kidney function returns back to normal in up to 9 months. So, from the systemic cascade, let's go to the mechanical trauma and local cascade. So it's called the local complications are related with vessel injury, and they are dissection, perforation, and stent damage if we're treating in-stent thrombosis. So the high-risk zones for thrombectomy are heavily calcified lesions, stent edges, angled and tortuous vessels, and thin-walled arteries. So we always should use the gentle glide technique, which is slow advancement of 1 centimeter every 2 to 3 seconds. Also, we should use the smallest possible catheter, which would be able to extract the thrombus, if that's possible. And if we feel any resistance, we should stop, readjust the catheter, and after that proceed with the thrombectomy. So how to treat dissections and perforations, we all know that. I'm not going to lose more time. So I'll move directly to the distal cascade. So the no reflow phenomenon, or the distal microembolization, is the most common issue which might occur. So it's a combination of microvascular obstruction from the microemboli plus peripheral vasospasm. So how to recognize it? Poor distal runoff, despite the perfect angiogram of the treated lesion. So also a sluggish contrast clearance and molted skin appearance on the fingertips or the front part of foot. So how to treat it? The first line medication, according to literature, is verapamil, 1 to 200 micrograms intraarterially through the catheter. Because of lack of the availability in our clinic of we use nitro. So how to prevent distal embolization? It's good to use filter wire, but we have another problem because the solenoid catheters, they're stiff and they're all 35 6 French systems, and the filter wires are usually all 14. So the whole system is super unstable, and when we are trying to do the thrombectomy, the filter is pulling in and out, which is not really good. And actually, during the thrombectomy, most of the microembolization occur not during the thrombectomy, but because there are underlying lesions. Some microthrombi are remaining between the stenosis. So after the post dilation, when we deflate the balloon, those microemboli are flushed distally. So my suggestion is, and this is what I usually do, I do the thrombectomy over O35 wire, and after that I exchange it with filter wire for the additional dilation. So there are another technique is described. I've never tried it, to push the thrombectomy catheter through a large 7 French or above guiding catheter and aspirate through catheter. That might help, actually. And also we should accept the incompetence clearance. Around 80-85% of thrombus clearance sometimes is enough, usually is enough. So perfectionists get complications. And of course, at the end, we should always complete with final angio distal and see how the contrast moves. So let's start with one of the cases, 81 years old male with incidence of arrhythmia, kidney disease, and short claudication for a short time. So you can see the initial angio CO2 and contrast. So first we start with the thrombectomy of the popliteal region, and on the mid-time angio, we see additional distal embolization in the tibial peroneal trunk. So we continue the thrombectomy, and the result in the treated area is quite good. But also we have some underlying chronic lesions which are treated with ballooning. And this is the final angio. So the treated area looks perfect. But now you can see how the contrast moves distally. So definitely we have some distal microembolic, of course, combined with vasospasm. So the patient was discharged with palpable pulses with no tissue loss, but in this particular case, with some intra-arteriously nitro administered, we fixed that. So another case of 74 years old male. So 8 months after the rethrombosis, he had a total subintimal fempop recanalization and total standing of the whole lesion. Right after the initial procedure, he had a rethrombosis, so he underwent catheter-directed fibrinolysis, and he was discharged with pedal pulses. 8 months later, he appeared with rethrombosis of the lesion, and we went for angiojet this time. Okay, this is the angio after the thrombectomy. You can see it's not perfect cleared, but also we have instant stenosis. So we proceed the procedure with ballooning with DCBs, and you can see the final result, perfectly opened fempop segment. But, oops, but despite that, I'm not sure how to, I would like to show you, no, it's not, come on. Anyway, the final angio, we had the same problem, very sluggish, very slow contrast in the arteries below the ankle. So that was caused by the same problem. Another issue, another complication is the compartment syndrome. I'm not going to lose time about it. You all know what it is, how to treat it. You all know how to and when to perform elective fasciotomy. So I'll continue. Bleeding is another additional complication. It's outside of those three cascades. It's most often most common in the groin area in the puncture site, and it most often occurs when we use the power pulse. Power pulse is another option for those of you who never used angiojet. It's an option for spraying 4 to 20 milligrams of TPA diluted in saline deep into the thrombus. So first we have initial fragmentation of the thrombus, and also it injects, let's say, the TPA deep into the thrombus, helping it easily to be lysed and sucked back. So in those cases, in all of the cases when I use power pulse option before the thrombectomy, I finish my procedure with using any kind of closure device, and after that I apply some mild compression for a couple of hours. So this is, you can take a picture of it if you want. This is a summarize of everything I told up here. So this is the prevention checklist for systemic, local, and distal complications before, during, and after the procedure. So we always should know which patients are suitable and which are not for angiojet. It's not a must procedure. So if we have patients with severe kidney disease, recent major surgery, extreme calcification, massive thrombus or long thrombotic lesion, or smaller vessels than 2 millimeters, we should try to find another revascularization option. Also, the interventionalist inexperience might be a contraindication too. This is the risk stratification algorithm I created just to for absolute contraindications and some mild contraindications, using angiojet to put only the most suitable patients for those kind of thrombectomy on the table. Otherwise, we should always know different. We should always have a backup plan to have different options. If we can use an aspiration device if it's available. Also, a hybrid procedure using open thrombectomy plus angio and ballooning or standing if needed. It's a great option. Of course, we can use catheter-directed thrombolysis, which is not my favorite option, definitely. So, instead of conclusion, I would like to say that prevention always risks, so we should do risk stratification and prophylaxis. We should never overexceed the thrombectomy time. We should check the aspirate in the urine for hemolysis. Sometimes perfectionists get complications, so 80 to 90% of thrombus clearance sometimes is quite enough for good long-term results. And good angiography of the treated area sometimes isn't equal to good final outcomes. So we should check for no reflow. We should check the tissues of the food and the color. So to break the cascade requires first prevention, detection of underlying issue, and the proper management. So if you decide to use angiojet for peripheral arterial thrombectomy, and if you decide to open the Pandora's box, please do it safely or don't open it at all. Thank you.
Very good presentation. I'll use this tomorrow.
It's a good toy, a good gadget, definitely.
Thank you very much.
So you know how to open the Pandora box.
Yeah, actually the learning curve is quite steep, but maybe in the last 3 years, me, Dr. Nikolov, and Dr. Georgiev, we have more than 70, I think, arterial cases. So yeah, our results are quite.
If you have a chance to choose 40 catheter or this device, what's your choice? The first choice.
First choice. Well, it depends on the patient. It depends on comorbidity, renal function. It depends, because I really like it, but it's not a must. So it depends on the underlying lesions. If we have a stented area before, if we have underlying multiple stenosis, if you have calcified lesions, this is something what I'm trying to do maybe in the near future to make kind of like an algorithm or question or something like that to put the right patient for the right procedure, which would be maybe useful for a department when angiojet is available to minimize complications and to maximize the outcome.
To choose
Fogarty
or
Fogarty plus angio or just angiojet. Yeah.
Thank you. Any questions?
Hello, everybody. I'm coming from Macedonia. We are not having the angiojet. We don't have penumbra. Some clinical in hospital in Skopje has, but we don't have it in Štip. But we are using our shortness for PHA. That means poor hospital improvisation technique. That means when we have this kind of situation, when we have this kind of situation, we try with the thromboaspiration. We try thromboaspiration. We try with the dedicated catheters. Afterward, with 7 French coronary catheter for thromboaspiration. And if we don't succeed with that, we go retrograde, put a balloon above the thrombotic plaque and pull it back everything with deflation of the balloon. And 100% is successful.
Like endovascular Fogarty with retrograde approach. Okay.
PHE.
Nice. Okay.
Poor hospital improvisation technique.
Okay. Other questions? No? Okay.
Thank you very much.
So, thank you, Dr. Dobrichkov, for the nice presentation. And the next lecturer is Dr. Zhezhovski. Okay.
Greetings, my name is Lachezar Dobrichkov, and I'm from University Hospital Burgas Med. I will be presenting a case of peripheral orbital atherectomy in advanced peripheral arterial disease, in patients with advanced peripheral arterial disease. So, advanced peripheral arterial disease is mostly tricky to treat, and most of the cases, its excessive calcification causes issues with balloon expansion, compromises stents deployment, and further compromises the procedural outcomes. So, what's the clinical imperative? The clinical imperative is calcium modification. How do we achieve that? We achieve that through a mechanism called differential sanding. Or exactly, the differential sanding refers to the preferential modification of rigid calcified plaques using diamond-coated crown. That diamond-coated crown selectively sands out calcium whilst preserving the compliant anterior tissue. It deflects back from the compliant arterial tissue. There are several indications and contraindications. So patient selection is mandatory. It's important to keep in track the vessel diameter, the lesion morphology, as well as the tortuosity or angulation of the vessels. There are several contraindications. I want to emphasize that I have placed the coronary artery use as a contraindication because for this particular device, it is contraindicated, though there are devices which support the orbital atherectomy. It's mandatory to use special guide wire. In our case, it's the Viper Wire Advanced. And it's extremely important to follow the procedural technique with the respective treatment periods and the rest periods to avoid vessel damage. There are several crowns available for the peripheral orbital atherectomy, and which one we use is exceptionally clinical. decision based on the vessel morphology, vessel diameter, as well as whether we want to go below the knee or we want to target mainly bigger vessels. So I will present two cases. The first case is for 76-year-old female, and that presented with non-healing wounds of the right foot and lower leg. So there's a small backstory of that patient. When we began, at first, that was several months before the orbital atherectomy. This patient arrived with totally occluded superficial femoral artery, right superficial femoral artery, with barely discernible distal target. And albeit the following recanalization, the result was suboptimal due to the extensive calcifications. So this is the vertical CT of the patient. You can notice the severe calcification. So we took a decision, entirely clinical based, to talk it through with the patient, because in this case, this procedure is not reimbursable, and the patient has to pay for everything. In this case, we made the decision to buy this device with her consent and to perform the procedure. You can notice the intraoperative angiography, and that was after we managed to somehow recanalize the superficial femoral artery. The multisegmental stenosis you notice are entirely comprised of calcium. So we began with the intervention. We crossed the lesions using an stato wire, and then under the support of microcatheter navicross, we exchanged with the Viper wire angiojet. Sorry, not angiojet. So we exchanged with the Viper wire, and then we began with the orbital atherectomy. First, you can notice to the left is the orbital atherectomy of the superficial femoral artery segment, then below the knee. We navigated the guide wire to the anterior tibial artery. Adjunctively to the orbital atherectomy, we did angioplasty of the superficial femoral artery segments as well as the anterior tibial artery, and we then also deployed a stent, a self-expandable stent, due to flow-limiting dissection at the end of the angioplasties. You can notice over the angiographic results the pre-procedure and the post-procedure angiographies. That's below the knee. That's below the knee, pre and after the intervention. Well, when I placed those images in here, they were mainly with the intention to make a comparison between the balloon dilation prior to the intervention and the balloon dilation after the intervention. You can see that after the intervention, the balloon literally inflates fully due to the compliant arterial tissue after the orbital atherectomy. The second case is of a 65-year-old male patient with comorbidities such as arterial hypertension, diabetes mellitus. He presented with bilateral foot wounds, given the fact that his left wound was pretty much critic. We decided to begin with his left leg first. So you can notice the necrosis on the distal phalanges of the third and fourth digits. This is pre-operative. So what happened with this patient? He also undergone orbital atherectomy, and he has also undergone orbital atherectomy. And as you can see, there is osteo superficial femoral artery to the left that is completely obliterated, and on the right image is subtraction, and these are below the knee vessels. So what we did is we crossed the lesions with the stato wire again. We navigated the guide wire to the anterior tibial artery under the support of Navicross microcatheter, and then we exchanged with the respective Viper wire. Then we began with the orbital atherectomy. Unfortunately, I'm not able to provide video material of this case, only images, but you can see the postoperative images of the supragenicular fragment and the infra and below the knee segments. I think I forgot to mention, but in the first patient we used the classic crown as well compared to this one. On the second patient we used the solid crown because we used the orbital atherectomy only above the knee. So this is a short comparison between the orbital atherectomy, between the before and after the procedure. This is below the knee comparison. On 6-month follow-up of the second patient, unfortunately, we weren't able to follow up the elder woman because I mean she had some issues with the trouble. She's not from Burgas. You can notice the superficial femoral artery and the popliteal arteries. Pre-procedure and 6 months after the procedural period, you can notice how the fourth digit is almost healed, whereas the third one still requires time. I do believe that that calcium modification in patients with advanced PAD is crucial, and patient selection is crucial. As main takeaways is that calcium modification is key in complex PAD intervention, and that orbital atherectomy works by improving vessel compliance through differential sanding, whose crown deflects back from the compliant arterial tissue and definitely sends out mainly calcium. Thank you.
Thank you for the perfect presentation. Any questions from the floor? Dr. Dobrichkov? Just wait for the microphone.
Yeah, I've never had the chance to use that device in real life. I mean, I tried it only on workshops. So I'd like to ask you, is it suitable for some elastic lesions or only for calcified lesions?
What lesions, sorry?
For elastic fibrotic lesions, I mean, with softer elastic plaques?
I mean, it could be useful. That's a very good question. I haven't had the experience to try it on such lesions, but we have only, so far we have only had 2 patients suitable for, no, many suitable for this procedure, but only 2 decided to continue and proceed further with the technique. I'm not quite sure if it's, I never had the clinical practice.
Okay.
In fact, it's not indicated. The mechanism of action is abrasion. It's in fact reducing the plaque, the calcific plaque only. It's not intended for fibrotic and more elastic lesions.
Thank you.
Yeah.
I have one question. Have you ever, these 2 cases are your only cases done?
Yep.
So has anybody in the floor used it in the patients with chronic kidney disease for infrapopliteal lesions?
In what relation?
In what relation? Due to the severe calcinosis, the circumferential calcinosis of the...
What is the relation with the kidney disease? I didn't understand.
Because, yeah.
Ah, yeah. I understand, yeah.
Okay. Thank you.
Thank you.